Welcome to the deep dive. Today, we're really zeroing in on something specific. Equine lamenesses you absolutely need to know for the BSCE veterinary test.
Exactly. We're digging into the equine lameness part 2 material.
Yep, the goal is to pull out the crucial stuff, make it stick, and hopefully make your BSCE prep a bit more efficient. Not just listing facts, but really understanding what's going on.
Right. Time's valuable when you're studying for the BSCE. So we want this to be a really practical, focused look at the common significant lameness issues.
Okay, let's jump in. First up, foot abscesses, subcellular abscesses. The document calls them very common.
Oh, incredibly common. You'll see these all the time.
What struck me, though, is the lameness scale. It says AAEP 15 all the way to 55. So barely lame to completely non-weight bearing. Why such a huge range for what sounds like a simple infection?
Well, the key thing to remember, especially for the BSCE, is the hook itself. It's rigid, right? There's no give. So when you get that pocket of pus, that abscess forming, the pressure builds up incredibly quickly. There's just nowhere for it to go.
Ah, okay. So that intense pressure against the sensitive bits inside the foot is what causes that sometimes really extreme pain.
Exactly. Even a small abscess can cause a 55 lameness because of that pressure cooker effect. It's a really important concept.
Makes sense. And the signs listed seem pretty classic. Heat in the hoof, feeling that stronger digital pulse.
Yeah, that bounding pulse.
Sometimes drainage popping out at the coronary band. It also mentions a sensitive spot on the coronary band and maybe a kind of vague response to hoof testers at first. So with hoof testers, what are we really trying to nail down? For the BSCE, I mean, are we just confirming foot pain or...
Well, initially, yes, you might just get a general ouch, that hurts somewhere.
Yeah.
But the real goal, especially with an abscess, is to find that specific pinpoint spot of extreme sensitivity.
Okay.
That really helps you localize where the abscess tract is likely coming to the surface, and that guides your treatment, where you might need to drain it.
Gotcha. And the cause is listed. Wow, it's quite a list. Poor hoof quality, maybe leftover damage from laminitis.
Yeah, anything that compromises the hoof wall or sole integrity.
Bruises, stepping on something sharp, obviously, even just wet, dry cycles messing with the hoof.
Definitely. Fluctuating moisture can weaken the hoof. Poor conformation can play a role too. And sometimes you just don't find a clear cause.
Yeah.
Idiopathic.
Right. So for the exam, should we basically know those main risk categories like poor hoof health, trauma?
Absolutely.
Yeah.
Knowing the common triggers is key for differentials and, client education later on. And recognizing that sometimes it is idiopathic is also part of it. You can't always pinpoint why.
Okay, so diagnosis. We suspect an abscess. We've used hoof testers. What's next? Radiographs mentioned. When do we actually need an x-ray for this, thinking about the BSCE?
Good question. Look, for your standard run-of-the-mill superficial abscess, you probably don't need radiographs.
Yeah.
But for the BSCE, think about when you would. If you suspect maybe a foreign object is involved, like a nail fragment.
Right, like if the history mentions stepping on something.
Exactly.
Yeah.
Or if the abscess seems really deep, or it's not responding as expected, or maybe it's in a weird spot. X-rays can also rule out other things, like, say, a coffin bone fracture, though that's less likely with typical abscess signs.
So treatment seems geared towards getting that pressure off. The document mentions palmar digital nerve blocks first.
Yeah, that's often step one. Numb the foot so you can actually work on it comfortably and safely.
Makes sense. Then probing, flushing, soaking, poulticing, and then using a hoof knife to open the tract. That sounds direct. What's the key principle there for the BSCE?
The absolute key principle. Follow the tract. Don't just go digging randomly. You want to carefully pare away hoof horn along the path the infection has already made, just enough to establish good drainage.
Okay, follow the tract, not create a massive hole.
Precisely. Minimal invasion, maximum drainage. The soaking and poulticing help draw everything out afterwards.
And then protecting the foot while it heals, checking tetanus status, always important.
Crucial. Any puncture wound, basically.
Pulling the shoe if needed. And it says systemic antibiotics are rarely used. Why is that? Seems like an infection. Shouldn't we use antibiotics? Good BSCE point, maybe.
Yeah, definitely a good point. The reason is the main problem is the trapped infection and the pressure. Once you establish drainage, the body's usually pretty good at clearing it up with local care. Systemic antibiotics just don't penetrate well into that kind of walled-off abscess, and they're usually not needed unless the infection is spreading up the leg, causing cellulitis, or involving deeper structures like bone or tendon sheath.
Got it. Drainage is king.
Pretty much. Oh, and the document also mentioned sometimes draining through the hoof wall, and a really practical tip. Always check for hot nails if the horse was recently shod. Could be a misplaced nail causing the abscess.
Good tip. Okay, the pearl sums it up. Crazy pain because of that trapped pressure. Right, let's shift gears. Laminitis, founder, another very common one, but feels like a whole different level of serious.
It absolutely is. Laminitis can be devastating.
The document mentions different stages: developmental, acute, chronic.
For the BSCE, what are the core differences we need to grasp?
Okay, so developmental stage. This is when the damage is starting biochemically within the laminae, those tissues holding the hoof wall to the coffin bone. But you don't see lameness yet. It's kind of silent.
Okay, hidden damage.
Exactly, acute stage. Now you see the clinical signs, the lameness, the heat, the pulses, but critically, the mechanical structures haven't permanently failed yet. There's still hope to prevent major displacement.
And chronic.
Chronic means that mechanical failure has happened, the laminar bonds are compromised, and you get that coffin bone rotation or sinking within the hoof capsule. That's when you see those long-term changes.
Right. Understanding those stages seems crucial for prognosis and how quickly you need to act.
Definitely. Time is critical with laminitis. The lameness is variable here too, but there's this specific OBLE grading system, grades 1 to 4. How should we think about those grades for the exam?
The OBLE grade is just a standardized way to describe how severe the lameness is clinically. Grade 1 is subtle, maybe shifting weight, lifting feet, but okay to walk. Grade 2, they're clearly stiff, short-strided, reluctant to turn. Grade 3, they're very lame at the walk, really don't want to lift a foot. Start adopting that sawhorse stance, maybe.
Leaning back off the toes.
Exactly. And grade 4 is the worst extreme pain, refusing to move, maybe even lying down and unable to rise easily.
Yeah.
Associating the grade with the level of pain and functional limitation is key for the BSCE.
Okay. And visually, the document shows those chronic signs: hoof rings wider at the heel, that dished hoof wall appearance, and the radiograph showing P3 rotation and a dorsal gas line. What's the deal with the gas line on an X-ray? Why is that significant for the BSCE?
Ah, the gas line. Yeah, seeing gas shadowing between the dorsal hoof wall and the coffin bone on a radiograph is a pretty serious sign. It indicates physical separation of those laminar tissues. It's direct radiographic evidence of that mechanical failure we talked about in chronic laminitis. Definitely a finding to recognize for the exam.
Got it. Separation, bad. Now, the causes, a big list again. Endocrinopathic things like insulin problems, EMS, Cushing's.
Very common triggers, especially pasture-associated laminitis.
Then inflammatory triggers, retained placenta, bad colitis, grain overload causing SARS.
Right, systemic inflammation overwhelming the system.
And then support limb laminitis, the horse overloading one leg because the other hurts.
A huge challenge to manage.
And just repeated trauma. For the BSCE, should we be focusing on understanding those broad categories of causes?
Absolutely. Knowing whether it's likely endocrinopathic, inflammatory septic, or mechanical helps guide diagnostics and treatment. Understanding those main pathways is crucial.
Okay, so diagnosis, signs are huge, obviously. But hoof testers, again, specifically over the toe, and looking for hoof rings, a coronary band ledge, what's that ledge about?
Yeah, hoof tester sensitivity over the toe is common, especially chronically, because the rotated tip of the coffin bone is pressing down there.
Makes sense.
And that palpable ledge or sort of sinking feeling at the coronary band, that's often a direct sign that the coffin bone has physically dropped or sunk lower within the hoof capsule due to laminar failure. Radiographs confirm this, showing the degree of rotation or sinking. Remember, though, acute X-rays might look normal initially.
Right, the damage can happen before it shows up on X-ray. Contrast venography is mentioned too, but maybe more specialized.
It is more specialized, yeah. It assesses blood flow, which can be compromised, but it's not routine everywhere.
Yeah.
Radiographs are the mainstay for assessing bony position.
Okay. And treatment sounds like a multi-pronged attack. Anti-inflammatories, pain relief, cooling the feet.
Cryotherapy, yeah. Especially crucial early on if you can catch it.
And lots of focus on hoof support. Special pads, boots like Soft Ride. What are the core principles of treatment we need for the BSCE?
Core principles. 1. Control pain and inflammation, NSAIDs, other analgesics, cryotherapy. 2. Address the underlying cause. If possible, treat the colitis, manage the EMS. 3. Provide mechanical support. This is huge. Reduce the stress on those damaged laminae using frog support, heel elevation sometimes, specialized shoes or boots.
Seems complex.
It is. And the document lists other things too. Tenotomy surgery in some cases, different meds, stem cells, even acupuncture. Really depends on the case, the cause, the severity. And sadly, sometimes euthanasia is the kindest option if the pain is uncontrollable or the damage too severe.
Yeah. The pearls mention that. Variable outcomes, damage happens before signs, treatment is intensive. Okay, let's move to degenerative joint disease. DJD, another very common one. Often older horses, but younger ones too.
Yep, absolutely. Age is a risk factor, but DJD, or arthritis, can definitely affect younger athletic horses due to wear and tear or specific injuries.
So for the exam, what are the classic signs that should make us think DJD?
Think joint effusion, that's swelling, or puffiness of the joint. Variable lameness, often worse after work or when starting work. Maybe some heat over the joint, and importantly, a decreased range of motion when you flex and extend it.
Okay, effusion, lameness, maybe heat, less movement. And after we localize the lameness to a joint, diagnosis relies heavily on x-rays.
Radiography is key, yeah. You're looking for those classic signs of arthritis. Osteophytes, those are little bone spurs around the joint margin.
Like in that picture of the pastern joint.
Exactly. Also, narrowing of the joint space, maybe increased bone density underneath the cartilage, called sclerosis. Ultrasound can be useful too, especially for looking at the cartilage surface itself, the joint capsule, and confirming effusion.
So x-rays for bone changes, ultrasound adds soft tissue detail. What's the main takeaway for the BSCE regarding imaging for DJD?
Understand what each modality shows you. Radiographs show the bone's response to the disease. Ultrasound gives you insight into the non-bony structures within and around the joint. Using them together gives a fuller picture.
And treatment. Sounds like it depends on a lot of factors. Severity, joint, age, use, cost. For the BSCE, what are the main treatment categories we should know?
Think broad categories. First, conservative management, rest, controlled exercise or rehab. Second, managing inflammation and pain, NSAIDs, maybe icing. Third, intra-articular treatments, injecting things directly into the joint, like corticosteroids, hyaluronic acid, or biologics like PRP or stem cells.
Joint injections, right.
Yeah. Then there are adjunctive therapies like shockwave. And finally, more aggressive options for specific situations like arthroscopic surgery to clean up the joint, or even arthrodesis, fusing the joint, particularly in lower motion joints like the pastern or lower hock joints.
Okay, lots of options tailored to the horse. The pearls say it's a vicious cycle of damage and inflammation, and outcomes vary. Management, retirement, new job.
Exactly. It's usually about managing the condition, not curing it.
And it distinguishes DJD from things like wind puffs, Therapin, Bogsbaven. What's the key difference there for the BSCE? Why aren't those considered DJD?
The key difference is that those conditions, wind puffs in the fetlock, Therapin in the tarsal sheath, Bogsbaven in the main hock joint, are primarily just fluid accumulation like synovitis or tenosynovitis. They don't inherently involve the progressive cartilage breakdown and bony changes that define DJD. They can sometimes be associated with underlying issues, but often they're relatively benign, maybe just a cosmetic blemish or causing mild, if any, lameness.
Gotcha. Fluid without the underlying joint destruction. Okay, next up, soft tissue injury. Tendons, ligaments, joint capsules. Very common, especially in athletes, so definitely BSCE relevant.
It's hugely relevant for sport horses, yeah. Any of the structures can be strained or torn.
Acutely, what are the telltale signs we look for in an exam situation?
Acutely, you're looking for those cardinal signs of inflammation right over the injured structure. Heat you can feel, pain when you palpate it, visible swelling, and of course lameness, which can range from mild to severe depending on the injury.
Pretty straightforward inflammation signs. What about chronic injuries? They sound trickier.
They can be more subtle, yeah. Chronically, you might just feel some mild thickening of the tendon or ligament compared to the other leg. Maybe still painful on deep palpation. The lameness might be more persistent, low grade, or maybe only obvious under certain conditions, like on soft ground or when ridden.
And for really figuring out what's going on, especially with these, the go-to diagnostic is
Ultrasonography. Absolutely essential for soft tissue.
why ultrasound?
Because x-rays only show bone. Ultrasound lets you see the actual tendon or ligament fibers. You can see disruptions, tears, core lesions, swelling, fluid hematomas. It's crucial not just for diagnosis, but for grading the severity, guiding treatment, and monitoring the healing process over time. That image of the prepped fetlock is typically you'd scan that whole area.
Right, so ultrasound is the window into those soft tissue. Treatment, again, starts with rest and rehab. What else is in the toolkit for soft tissue injuries for the BSCE?
Beyond rest and careful exercise, anti-inflammatories are key, usually NSAIDs initially, maybe topical treatments. Cryotherapy, icing, is important acutely. Injecting the lesion itself is sometimes done maybe with steroids cautiously, or often biologics like PRP or stem cells to try and improve healing quality. Shockwave therapy is also used quite a bit.
Okay. And the pearls? Lists some big players, often injured. Definitely need to know these for the BSCE. SDFT, superficial digital flexor tendon, the classic bowed tendon.
Yep, very common, especially in racehorses.
DDFT, deep digital flexor tendon, with that risk of rupture if there's navicular disease.
Yeah, the DDFT runs right over the navicular bone, so disease there can weaken it.
Suspensory ligament associated with those catastrophic breakdown injuries, sometimes with sesamoid fractures.
A major cause of lameness and retirement in sport horses.
Any others we should specifically flag?
The document mentions distal pastern ligaments too. They can be tricky. And definitely injuries within the stifle cruciate ligaments, menisci, are significant causes of hind limb lameness that you need to be aware of for the BSCE.
Okay, now navicular syndrome or heel pain, also very common. Forelimbs, quarter horses over 8 seem predisposed, slow onset, often bilateral.
Yep, classic presentation, though other breeds get it too, of course.
For the BSCE, what diagnostic clues during the lameness exam scream navicular area?
Several things. A positive response, meaning the lameness improves significantly to a palmar digital nerve block, is probably the biggest indicator.
Numbing the heel.
Exactly. Also sensitivity when you press firmly between the heel bulbs. Sometimes pain response to hoof testers, specifically across the frog and heel area. And often the lameness gets worse after a lower limb flexion test.
Okay, block, heel palpation, frog testers, flexion test. Radiographs are used, but the document makes a point that the X-ray changes don't always match how lame the horse is. What kind of changes might we see, and why the disconnect? Relevant for the BSCE, I assume.
Highly relevant. On X-rays, you might see things like enlarged channels in the navicular bone where blood vessels go, those lollipops, or enlarged synovial invaginations. You might see sclerosis, meaning the bone looks denser, wider. Maybe some bony spurs or mineralization where ligaments attach.
But the horse could have nasty X-rays and be sound, or clean X-rays and be lame.
It happens. That disconnect tells us navicular syndrome isn't just about bone changes visible on X-ray. It's a complex involving the navicular bone itself, the ligaments around it, the navicular bursa, the DDFT. There's a lot going on in that small area. So clinical signs and response to blocks are really important pieces of the puzzle. The images show some of those bone changes and also a navicular bursa lavage flushing the bursa.
Right, it's a syndrome, not just one thing, and it's about management, not usually a cure. What are the key management strategies we need to know for the BSCE?
Okay, mainstays for the BSCE. First, hoof care is critical. Trying to reduce stress on the navicular apparatus. This usually means careful trimming and shoeing to achieve a good hoof pastern axis, maybe shortening the toe, sometimes elevating the heel slightly, using shoes like egg bars or heart bars for support.
Shoeing is big.
Huge. Second, medications.
Yeah.
NSA aids for pain relief during flare-ups. Isoxsuprine used to be common, thought to improve blood flow, but its efficacy is pretty questionable now. Bisphosphonates, like Tildren or Osphos, are used to modulate bone remodeling.
Okay.
Third, injections. Corticosteroids or other agents injected directly into the coffin joint, or more specifically, the navicular bursa. And fourth, as a last resort or salvage procedure, palmar digital neurectomy, cutting the nerves to numb the heel permanently.
The nerving, but there are risks, right?
Big risks. The main one being potential rupture of the DDFT later on, because the horse loses protective sensation. Also, neuromas can form. It's definitely a salvage option with significant potential downsides, crucial to remember for the exam.
Definitely. Okay, last one. Fractures. Less common overall than the others, it says, but obviously critical.
Yeah, uncommon compared to, say, an abscess or DJD, but you absolutely have to be able to recognize and deal with them for the BSCE.
Signs seem super variable depending on, well, everything. Open, closed, complete, incomplete location.
Exactly. Lameness can be anything from mild, like a chip fracture, to absolute non-weight bearing, a complete long bone fracture. Swelling can be minimal or massive. The horse might be calm or in shock.
So given that variability, what's the absolute must-do for diagnosis, according to the document?
It emphasizes you must completely understand the fracture configuration. That's the key takeaway for the BSCE. You need to know exactly what you're dealing with. Simple versus committed multiple pieces, displaced versus non-displaced, joint involvement, because that dictates treatment and prognosis.
How do we get that understanding? Diagnostics.
Physical exam first, obviously. Careful palpation if possible, but imaging is essential. Radiography is the workhorse for most fractures. You need multiple views to really map it out. Ultrasound can sometimes help, especially for visualizing the surface of bones or identifying associated soft tissue damage. And for really complex or subtle fractures, especially around joints or in the upper limb or pelvis, you might need nuclear scintigraphy, bone scan, CT, or MRI.
Got it. Imaging is key to understand the configuration, and treatment, also highly variable. General principles for the BSCE. Treatable versus less treatable.
General principle.
Yeah.
Location, location, location.
Mm-hmm.
And age size. Distal limb fractures, cannon bone, pastern, coffin bone often have a better prognosis for surgical repair, especially in younger animals.
Lower leg, better chance.
Often, yes. Fractures higher up get much harder. Radius and tibia fractures in adult horses are very challenging. Humerus, femur, pelvis fractures in adults are generally considered catastrophic and non-repairable due to the horse's size and the difficulty of fixation. Surgical options include plates and screws, internal fixation, external fixators, pins, and casts. And of course, rest and careful management are vital components.
And the Pearl notes the most common long bone fracture is the diaphyseal cannon bone fracture. Good factoid for the exam.
Definitely one to remember.
Okay, for you. So that was a pretty intensive run through of 6 key equine lamenesses, all stuff that's really central for the BSCE vet test prep. We hit the causes, the signs, the diagnostics, the treatments. Hopefully pulling it all together like this gives you a solid framework for studying this material further.
Yeah, absolutely. Having a good grasp of these conditions, the mechanisms, how they present, how you diagnose and approach treatment that's fundamental for the BSCE.
Right. So as you keep studying, here's something to maybe mull over. Think about how interconnected all this stuff is, like how chronic laminitis can mess up hoof structure and maybe predispose to abscesses.
Or how navicular changes can put strain on the DDFT.
Exactly. Or how maybe a ligament injury leads to joint instability, which then contributes to DJD down the line. What does all that linkage tell us about needing a really holistic sort of whole horse view when we're diagnosing and treating lameness in equine practice? It's rarely just one isolated thing, is it?
That's a great point. It really underscores the need to look at the bigger picture, how all the parts of the musculoskeletal system work together or fail together.
Something to think about. Anyway, thanks for joining us for this deep dive.